It was the late 1990s, and Dr. Murray Raskind had a problem he couldn't solve. He was a psychiatrist at the VA Puget Sound healthcare system in Seattle, working with Vietnam veterans, men who had been home from the war for decades. They had done therapy. They had tried medications. They had waited. And still, every single night, without fail, the dreams came back. Not ordinary bad dreams. The same memories, replaying with surgical accuracy. The same sounds, the same faces, the same sensation of absolute terror, as vivid at 3 a.m. in a quiet suburban house as it had been in the jungle 30 years earlier. Some of these men had started keeping loaded weapons beside their beds. Some were walking the perimeters of their homes at night, checking the edges. Some hadn't slept more than a few hours at a stretch in years. Nothing in the clinical toolkit touched it. Then Raskin had a thought. He noticed something in the pattern of these nightmares. The way they felt less like dreams and more like adrenaline storms. The body wasn't just dreaming. It was activating, heart pounding, muscles rigid, every biological alarm firing simultaneously. What if, he wondered, the problem wasn't in the mind at all, but in the chemistry? What if the norepinephrine system, the same biochemical cascade that had kept these men alive in combat, had never properly deactivated? He began searching the pharmacology literature and found exactly what he was looking for. An old, inexpensive blood pressure drug called prazosin, approved by the FDA in 1976, used by millions of people to treat hypertension and prostate problems. Almost nobody in psychiatry had ever thought about it. But crucially, it crossed the blood-brain barrier, and it blocked the exact receptor that norepinephrine uses to sustain the brain's arousal response. He began prescribing it to his patients. Within days, the nightmares stopped. Not for everyone, not permanently, but for men who hadn't slept through the night in 30 years, the silence was staggering. What Raskin had stumbled onto, through careful clinical reasoning, not accident, was a window into one of the most astonishing and poorly understood processes in all of neuroscience. A process that happens inside every one of our minds, every single night. A process that, when it works, gently dissolves the emotional sting of even our most painful experiences. And when it fails, for reasons that are only now becoming clear, leaves a person trapped inside their own memory, unable to escape it, even in sleep. This is the story of what sleep actually does to trauma. What happens to the brain in the night when the wound is too large. Why some people cannot simply be told to rest. And what it means that a blood pressure pill and an obscure theory about brain chemistry may have accidentally mapped the mechanism by which the mind heals itself. Settle in. Take a slow breath. This is a story worth knowing. Before we continue, understand the relationship between trauma and sleep. We need to be precise about what trauma actually means, because the word has been stretched wide in everyday conversation, and the clinical science is more specific than the cultural use tends to be. In psychiatric terms, trauma does not refer simply to a difficult experience. It refers to an experience that overwhelms the nervous system's capacity to process and integrate what has happened. The DSM-5, the American Psychiatric Association's Diagnostic and Statistical Manual, 5th edition, defines a traumatic event as exposure to actual or threatened death, serious injury, or sexual violence, whether experienced directly, witnessed in person, learned about when it happens to someone close, or encountered repeatedly, as is common among emergency responders and crisis workers. What matters in that definition is a threshold, a point at which the ordinary mechanisms of emotional processing are exceeded. Like a circuit that trips when the current is too high. Not everyone who crosses that threshold develops PTSD. Research consistently shows that most trauma survivors experience some initial disruption: nightmares, intrusive thoughts, difficulty sleeping, emotional numbness, but that these symptoms begin to ease within the first few weeks, as the nervous system gradually integrates the experience. The brain, under ordinary circumstances, is equipped to recover. Post-traumatic stress disorder is what happens when that recovery does not come. When symptoms persist beyond a month, cause significant distress, and begin to constrain a person's life, relationships, work, health, identity. According to the World Health Organization, approximately 3.9% of the global population will develop PTSD at some point in their lifetime. The National Center for PTSD estimates around 7.7 million American adults are affected at any given time. And woven into almost every single case, like a signature, is a profound disturbance of sleep. Here is something worth sitting with. What we now call PTSD has been part of human experience for as long as human beings have faced overwhelming danger. What changed across the centuries was not the suffering. It was whether anyone believed it was real. Researchers studying ancient Mesopotamian clay tablets from the Assyrian dynasty, texts written between approximately 1300 and 609 BC, have identified accounts of soldiers returning from battle who were tormented by visions of the enemies they had killed, who could not sleep, and whose behavior had become erratic and disturbed. Modern scholars, including those writing in the journal Early Science and Medicine, have noted that the symptom patterns recorded on these tablets, flashbacks, sleep disruption, low mood, intrusive memories, match closely what we would now recognize as trauma-related responses. Of course, applying a contemporary clinical framework to ancient texts requires care. These are scholarly inferences, not retrospective diagnoses. But the pattern recurs with enough consistency that it is reasonable to consider these among the earliest documented human encounters with what trauma does to the mind. The Greek historian Herodotus, writing around 430 BC, recorded the case of an Athenian soldier named Epizelus, who was struck blind during the Battle of Marathon in 490 BC without any physical wound. Surgeons examined him at the time and found no injury. Epizelus reported that he had seen a massive armored phantom kill the man fighting beside him, and from that moment, he could not see. The blindness lasted for the rest of his life. Modern clinicians have suggested this account could be consistent with what we now call a conversion disorder, a neurological symptom arising from acute psychological trauma, in which the mind generates a genuine physical impairment in the absence of any structural damage. It is a retrospective interpretation across 25 centuries of distance, and we should hold it lightly. What is not in doubt is that Herodotus considered it worth recording, and that the surgeons of his time could offer no physical explanation. The pattern continued through the centuries in various guises. In 1597, Shakespeare described the symptoms with remarkable clinical precision, even without any clinical framework to hold them. In Henry IV, Part 1, Lady Percy watches her husband Hotspur struggle through the night. In thy faint slumbers I by thee have watched, and heard thee murmur tales of iron wars. A soldier, returning from battle, reliving the fight in dreams. Any clinician reading that passage today would recognize it immediately. The 19th century gave the phenomenon new names. As industrial railway accidents became more frequent, survivors presented with persistent anxiety, sleep disruption, and what physicians called railway spine, initially blamed on hidden physical damage to the nervous system. After the American Civil War, the surgeon Jacob Mendez da Costa studied veterans presenting with heart palpitations, chest pain, and fatigue, symptoms he attributed to cardiac overstimulation, calling the condition soldier's heart, or da Costa's syndrome. In retrospect, the overlap with what we now understand as trauma-related physiological hyperarousal is striking. Though, at the time, the psychological dimension was not recognized. Then came the First and Second World Wars, and a reckoning that medicine could no longer avoid. Shell shock entered medical literature in 1915, used to describe the tremors, paralysis, mutism, nightmares, and extreme startle responses seen in soldiers returning from the Western Front. Initially, many physicians believed these symptoms were caused by the physical concussive force of nearby artillery, a literal shock to the nervous system. But as it became clear that soldiers who had never been near an explosion were experiencing identical symptoms, the medical establishment was forced to confront something more uncomfortable. The mind could be shattered by overwhelming experience without leaving a single visible wound. Even then, understanding was incomplete, and treatment was often brutal. Electric shock, rest cures, the implicit accusation of weakness. The Second World War produced the term battle fatigue, and the scale of psychiatric injury was staggering. Based on data from the National World War II Museum and verified historical records, more than 500,000 American service members suffered psychiatric collapse during the war, and psychiatric conditions accounted for 40% of all medical discharges. Military medicine was finally, reluctantly, forced to accept that there was no such thing as a psychologically immune soldier, that under sufficient and sustained pressure, the human nervous system would eventually break. The path to formal recognition was long, contested, and profoundly political. The DSM-2 in 1968 actually omitted the predecessor diagnosis, meaning that veterans returning from Vietnam in the years that followed had no official psychiatric category for what they were experiencing. It took years of sustained advocacy from veterans, from Holocaust survivor groups, and from feminist researchers and clinicians who had been documenting the lasting effects of sexual violence to change this. In 1980, the American Psychiatric Association formally added post-traumatic stress disorder to the DSM-3, placing the cause of the disorder not in the character of the individual, but in the nature of the event. For the first time, psychiatric medicine said plainly, there are forms of experience so extreme that they would cause significant distress in almost anyone. That reframing was one of the most important acts of recognition in modern medicine. In 2013, the DSM-5 moved PTSD out of the anxiety disorders and into its own new category, trauma and stressor-related disorders, reflecting growing understanding that PTSD involves far more than fear. It involves changes in mood, cognition, identity, and centrally to everything we're exploring tonight, sleep. To understand why trauma so profoundly disrupts sleep, we need to look inside the brain, because what trauma does there is measurable, observable, and now extensively documented. Three structures sit at the center of this story: the amygdala, the hippocampus, and the medial prefrontal cortex. The amygdala is the brain's alarm system, a small almond-shaped cluster of neurons located deep in the temporal lobe, whose primary role is threat detection. When you perceive danger, the amygdala fires rapidly, triggering the release of cortisol and norepinephrine, accelerating the heart, tensing the muscles, and narrowing your attention to the source of threat. This is the fight-or-flight response, and it is exquisitely well designed for exactly the kind of dangers our ancestors faced. Under normal circumstances, once the threat has passed, a region of the medial prefrontal cortex, specifically the ventromedial prefrontal cortex, sends a calming signal back down to the amygdala. The danger is over. Stand down. The body gradually returns to baseline. In individuals with PTSD, this circuit is dysregulated in two directions at once. The amygdala becomes hyperreactive, firing more intensely and more readily, responding to stimuli that the brain has associated with the original trauma. A smell, a sound, a quality of light, a texture. Any of these can trigger the full alarm response, as though the original danger is actively present. Simultaneously, the prefrontal cortex becomes underactive, less capable of sending the calming signal back down. The alarm is easy to trigger and very hard to silence. Neuroimaging research, extensively reviewed by J. Douglas Bremner and colleagues at Emory University and published across peer-reviewed literature, consistently shows that people with PTSD demonstrate smaller, hippocampal and anterior cingulate cortex volumes, increased amygdala reactivity, and decreased medial prefrontal cortical activity compared to trauma-exposed individuals who did not develop PTSD. Research from the Karolinska Institutet in Stockholm, examining 39 trauma survivors, found that higher levels of sleep disturbance were significantly associated with reduced gray matter volume in the amygdala, hippocampus, and anterior cingulate cortex, the very regions most implicated in both emotional regulation and sleep. The hippocampus deserves particular attention here. Shaped like a seahorse and located within the temporal lobe, the hippocampus is responsible for contextualizing memory, placing experiences correctly in time, in space, and in relationship to other experiences. Under normal circumstances, when the amygdala fires in response to a triggering stimulus, the hippocampus supplies the crucial context. Yes, that sound resembles a gunshot, but we are here. We are safe. This is now. That was then. In PTSD, this contextualizing function becomes unreliable. The hippocampus, under the chronic stress of elevated cortisol and persistent arousal, becomes compromised in its organizational work. Memories of the traumatic event lose their proper temporal framing, their sense of being past. Instead of being experienced as memories, they erupt into the present with the full sensory and emotional immediacy of the original moment. This is the neurological mechanism behind flashbacks. Not imagination, but a failure of the hippocampus to properly contain the past where it belongs. And the HPA axis, the hypothalamic pituitary adrenal hormonal cascade responsible for regulating the stress response, becomes chronically dysregulated. Some individuals with PTSD show persistently elevated cortisol. Others, paradoxically, show chronically blunted cortisol, a sign that the system has become exhausted. Either way, the chemistry of the resting brain is no longer what it should be, and this altered chemistry floods into sleep, shaping every stage of what the night should restore. To appreciate what trauma does to sleep, you first need to understand that sleep is not a single uniform state. It is an architecture, a cycling sequence of distinct stages, each with its own neurological character and its own essential purpose. A healthy night moves through 4 to 6 complete cycles, each lasting roughly 90 minutes. Each cycle contains stages of non-rapid eye movement sleep, or NREM, followed by a period of rapid eye movement sleep, REM. In the early part of the night, the deepest stages of NREM dominate. This is slow wave sleep, defined by large, synchronized electrical oscillations sweeping across the brain, and it is associated with physical restoration, immune function, the release of growth hormone, and the consolidation of declarative memories. Facts, events, learned information, all being transferred from short-term hippocampal storage into more stable, long-term cortical networks. As the night progresses toward morning, the balance shifts. REM sleep periods grow longer with each successive cycle. And REM sleep is where something extraordinary and still not fully understood happens. During REM sleep, the brain is almost as metabolically active as during full waking consciousness. The amygdala, hippocampus, insula, and areas of the prefrontal cortex all show elevated activity. Vivid dreaming occurs. But the most significant feature of REM sleep, the feature that connects directly to everything Murray Raskind would later deduce, is neurochemical. During REM sleep, and at no other time in the 24-hour cycle, the brain dramatically reduces its output of norepinephrine. The stress system grows quiet. The neurochemical environment of the sleeping brain becomes, for this brief window, calmer than at almost any other moment of conscious or unconscious life. Researcher Matthew Walker at the University of California, Berkeley, building on earlier work and publishing in Current Biology in 2011 alongside Els van der Helm, described REM sleep as a form of overnight therapy. The brain, in this quiet chemical space, retrieves emotionally charged memories and represents them to itself, allowing them to be reprocessed without the same flood of stress chemistry that originally encoded them. What Walker and Vanderhelm called affective demodulation. The gradual stripping away of the acute emotional charge from an experience so that the memory can eventually be held and recalled without triggering the full alarm response. Put simply, this is how we heal from things that frighten us. This is the mechanism by which yesterday's terror becomes, over the course of weeks and months of nights, simply something that happened. And now you can perhaps sense, already, what goes wrong when trauma is involved. Here is the first real twist of tonight's story, and it changes everything about how we understand PTSD. The nightmare is not the brain torturing its owner. The nightmare is the brain trying to heal and failing. In people with PTSD, the elevated norepinephrine that characterizes their waking hyperarousal appears to persist into REM sleep, or at least not to fall to the levels required for healthy emotional processing. Research suggests the adrenergic system, overactivated by trauma, remains too loud even during what should be the brain's quietest hours. And so, when the sleeping brain reaches for the traumatic memory, as it reaches for every emotionally significant experience, trying to run its overnight therapy protocol, it finds itself attempting to process that memory, not in a calm neurochemical landscape, but in a brain that is chemically nearly indistinguishable from a state of waking terror. The process fails. The memory surges back with full force. The person wakes, heart racing, body flooded with adrenaline. The terror of the original event, indistinguishable from present experience. And then the brain tries again the next night, and the next, and the next. The repetition of the nightmare is not random, and it is not cruelty. It is the brain's compulsive, exhausting, failing attempt to do something it was designed to do, to process the experience and reduce its charge, over and over. Because the conditions required for success are never quite achieved. This is what Murray Raskin had reasoned his way toward in the late 1990s, before the neuroscience had fully caught up to his clinical intuition. If the problem was excess norepinephrine preventing the brain's healing process from completing, then a drug that quietly reduced norepinephrine's grip during sleep might give the brain what it needed to finally finish the work. He was right, at least for some patients. And this is where accuracy requires a pause, because the prazosin story is not perfectly clean. While Raskin's early trials, and several subsequents, controlled studies showed meaningful reductions in nightmare frequency and sleep quality for many veterans. A large multi-site VA trial, published in the New England Journal of Medicine in 2018, involving more than 300 combat veterans, found that prazosin performed no better than placebo overall. Raskin himself, as lead author on that trial, acknowledged the result while noting that subgroups of patients with higher baseline norepinephrine activity, indicated by higher standing blood pressure, did appear to benefit significantly. The picture, as often with psychiatric medicine, is complicated. Prazosin remains in clinical use, particularly in VA settings, but the field now understands it is not a universal solution. It appears to help those whose PTSD involves the most marked adrenergic overactivation, and to do little for those whose symptoms are driven by different mechanisms. What the story of prazosin illuminates, even with its complications, is the central question: why does the traumatized brain fail to heal itself at night? And the answer, increasingly, is that the very system the brain uses for healing, REM sleep and its quiet chemistry, is disrupted at the source. For decades, the relationship between trauma and sleep was understood in a single direction. Trauma causes PTSD. PTSD causes sleep disturbance. Treat the trauma, and the sleep will eventually follow. We now know this picture is wrong, or at least deeply incomplete. The relationship between sleep disturbance and PTSD runs in both directions. And this discovery, while it may sound like an academic footnote, changes clinical practice in profound ways. Research synthesized by Edward Pace Schott and colleagues at Harvard, published in Biology of Mood and Anxiety Disorders in 2015, made this case with particular clarity. Sleep disturbances prior to or shortly after a traumatic event significantly increase the risk of subsequently developing PTSD. People who already had sleep problems before a traumatic exposure were substantially more likely to go on to develop post-traumatic stress disorder, even after controlling for the severity of the exposure itself. In one study, patients admitted to an emergency department following a motor vehicle collision who reported pre-existing insomnia and nightmares were significantly more likely to develop PTSD in the months that followed, independent of how serious the collision had been. Research published in Frontiers in Psychiatry described this with directness that the field had not previously used. Sleep disturbance is not merely a symptom of PTSD. It is a predisposing, precipitating, and perpetuating factor. Why should poor sleep before a trauma increase vulnerability to PTSD afterward? The answer lies in a process called fear extinction, the brain's ability to learn that something once threatening is no longer dangerous. Exposure-based therapies for PTSD are built on this mechanism. Controlled, graduated re-exposure to trauma cues in a safe setting, allowing the brain to form new associations that overwrite the old alarm response. Fear extinction is not forgetting. It is learning something new that competes with the old learning. And REM sleep, research shows, is essential for consolidating this learning. When people undergo fear extinction training and then sleep, the extinction memory is significantly better retained. The brain holds on to the safety learning. When REM sleep is disrupted, this consolidation fails, and the fear returns more readily, as if the safety lesson was never fully recorded. Neuroimaging work confirms this. Sleep containing adequate REM promotes re-engagement of the ventromedial prefrontal cortex, the region responsible both for inhibiting the amygdala and for encoding extinction memories, during subsequent fear-related recall. In other words, sleep doesn't just rest the brain, it practices safety. It rehearses and encodes the biomyosins, lesson that danger has passed. A person entering a traumatic event with already disrupted sleep is, in a sense, arriving with the system already compromised. The brain is less equipped to do the nightly work of integrating and contextualizing distressing experience. When the traumatic event occurs, the system that would normally help with recovery is already struggling. And then the loop begins. Trauma disrupts sleep. Disrupted sleep impairs the brain's capacity to process trauma and consolidate safety learning. This worsens PTSD symptoms, which further disrupts sleep, which further impairs processing, which worsens symptoms. Each revolution tightens the cycle. This changes everything about treatment priority. Improving sleep in PTSD patients is not supportive care or an optional adjunct. It may be one of the most direct therapeutic levers available, and Pace Schott and colleagues proposed in their review that timing exposure-based therapy to be followed by good sleep, or treating sleep disturbances before or alongside trauma therapy, could meaningfully improve treatment outcomes across the board. The field is beginning to take this seriously together. There is a form of trauma-related experience that deserves its own careful attention, not because it is more dramatic, but because it is so often misunderstood, and because its relationship with sleep is particularly profound. Complex PTSD was formally recognized in the World Health Organization's International Classification of Diseases, the ICD-11, in 2018. It arises from prolonged, repeated traumatic experiences, particularly those involving interpersonal violence, captivity, or abuse within childhood, in situations where escape was difficult or impossible, and where the trauma occurred within relationships that were supposed to be safe. In complex PTSD, all the features of standard PTSD are present: intrusion, avoidance, hyperarousal. But there are additional layers. profound. Difficulties with emotional regulation, deep and chronic shame, a damaged or fragmented sense of self, and persistent difficulties trusting relationships. The nervous system was not disrupted by a single overwhelming event. It was shaped, during its formative period, by an environment of repeated threat. Research suggests that up to 90% of individuals with complex PTSD experience significant sleep disturbance, and the patterns of difficulty are more pervasive and more treatment resistant than in single-event PTSD. The core challenge is hypervigilance. Sleep requires a form of surrender, a relaxation of vigilance, a release of the monitoring of the environment, a willingness to lose conscious awareness. For a nervous system that learned during childhood that sleep was not safe, that unconsciousness meant exposure, this surrender is not simply difficult. It is, at the level of the autonomic nervous system, registered as dangerous. Night itself becomes associated with threat. The darkness, the quiet, the aloneness. These are not neutral signals, and are not processed as such. The body responds before the conscious mind has registered anything alarming. A person may find themselves lying in the dark with heart already elevated, senses straining, body braced, before they have thought a single frightening thought. This is conditioning operating below deliberate awareness. It is what we might expect to find in a nervous system that learned, very early, that night was the time when things went wrong. The chronically poor sleep that results cascades into everything. Emotional regulation, already compromised by the developmental effects of complex trauma on the prefrontal cortex, is further undermined by sleep deprivation. Exhaustion makes the emotional symptoms harder to manage. Harder emotional symptoms make sleep more difficult to achieve. The person fights a war during the day and faces a different kind of conflict every night, without the rest that would allow either battle to resolve. Understanding this does not make the path forward simple, but it makes it comprehensible. The sleeplessness of complex PTSD is not a failure of will or self-discipline. It is the predictable, coherent consequence of a nervous system doing exactly what it learned to do, in conditions that no longer require it. The science that has uncovered how deeply sleep and PTSD are entangled has also opened up new and increasingly effective paths toward repair. There is genuine reason for hope here. The most broadly recommended treatment for insomnia in the context of PTSD is cognitive behavioral therapy for insomnia, CBTI. This is a structured, evidence-based approach that targets the thoughts, patterns, and behaviors that perpetuate sleep difficulty, dismantling the cycle of hyperarousal and bed-related anxiety that trauma tends to establish. The National Center for PTSD reports that CBTY improves sleep in roughly 7 in 10 people who complete it. Importantly, research published in Frontiers in Psychiatry found that in PTSD patients, effective CBTI treatment also significantly reduced hypervigilance and overall PTSD symptom severity, suggesting that sleep and trauma are not separable problems at this stage. For trauma nightmares specifically, 2 treatments hold the strongest evidence base. The first is imagery rehearsal therapy, or IRT, developed substantially by Barry Krakow and colleagues. The approach is deceptively simple. The person selects a recurring nightmare, writes a new version of it with a different ending, any ending, realistic or fantastical, and then rehearses this reimagined narrative during the daytime. A meta-analysis drawing on data from over 1,000 participants, published in Sleep Medicine Reviews, found that IRT produces moderate effects on nightmare frequency, sleep quality, and overall PTSD symptoms, comparable in magnitude to medication-based approaches. The medication in question is prazosin, which, despite the complications noted in the 2018 large-scale VA trial, remains in clinical use for patients showing the specific biomarker profile: elevated standing blood pressure, that research suggests predicts a positive response. For those patients, the effects on nightmare frequency and overall sleep quality are substantial. And then there is EMDR, eye movement desensitization and reprocessing, which sits at a genuinely fascinating intersection of trauma therapy and sleep science. Developed by Francine Shapiro in 1987, EMDR involves the person holding a traumatic memory in mind while experiencing bilateral sensory stimulation, typically following the therapist's moving finger with their eyes, creating a rhythmic left-right pattern. It is recognized as an evidence-based treatment for PTSD by both the World Health Organization and the American Psychiatric Association, with substantial outcome data supporting its efficacy. Why it works is still debated. Several mechanisms have been proposed, and the science has not yet settled on a single answer. But one hypothesis is particularly striking in the light of everything we have explored tonight. Research by Marco Pagani and colleagues, published in Frontiers in Neuroscience, found that the bilateral eye movement pattern used in EMDR produces brainwave activity, measurable on EEG, that bears a resemblance to the slow oscillatory patterns of deep NREM sleep. If this finding is replicated and extended, it could suggest that EMDR creates, during waking consciousness, something that functions neurologically like the conditions the brain uses during slow-wave sleep for memory reconsolidation. It would mean, in other words, that EMDR might work not despite its apparent strangeness, but precisely because the brain already knows how to do what the therapy is simulating. This remains a working hypothesis, not a settled mechanism. But it is one that makes compelling sense within everything we have established. And if correct, it would offer a profound explanation. That for people whose sleep is too disrupted to complete the brain's own healing process at night, certain therapies may be able to create, in waking daylight, something close enough to the nightly conditions of repair. We have come a long way tonight, from the clay tablets of ancient Mesopotamia to a VA clinic in Seattle. From the trenches of the Western Front to the imaging suites where researchers have watched, in real time, the wounded brain trying to do what it was made to do. And here is what I want to leave you with. The nightmare is not evidence of a broken mind. It is evidence of a mind that refuses to give up. Every night, in every REM cycle, the sleeping brain reaches for the traumatic memory. It runs its processing protocol. It attempts to hold the experience in that quiet chemical space where healing is possible. It is not doing this randomly. It is doing it with purpose, with the same organized biological intelligence that has preserved this capacity through millions of years of human and pre-human history. In PTSD, that process keeps failing, not because the brain has surrendered, but because the conditions it needs are disrupted. The norepinephrine is too loud. The safety of the neurochemical environment of REM sleep cannot be reached, and so the brain tries again the next night, and the next. What looks from the outside like torture is, from the inside of the biology, an act of relentless effort. What prazosin does, for those patients for whom it works, is give the brain the quiet it needs to succeed. What IRT does is give the sleeping mind a new script to rehearse, a script where the ending is different. What CBTI does is reduce the systemic arousal that keeps the brain's alarm system firing through the hours of rest. And what EMDR may be doing, if Pagani's hypothesis is confirmed, is simulating in waking life the very conditions that sleep was always trying to provide. These treatments are not fighting against the brain. They are finally giving it what it was always asking for. The science of trauma and sleep is, at its deepest level, the science of the brain's own drive toward wholeness. That same drive that causes nightmares to repeat. That same drive that wakes a person at 3 a.m. with their heart already pounding. This is not the sound of a mind breaking down. It is the sound of a mind that has not stopped trying, night after night, in every available window, to bring its owner through to the other side of the wound. If any part of tonight's journey resonates with something you or someone you love is carrying, please know that support is available. Trauma-informed therapists, CBTI programs, and evidence-based PTSD treatments are accessible and effective. Reaching out is always a meaningful step, and you do not have to carry this alone. Thank you for spending this time here. If this journey through the sleeping mind has been valuable, a quiet like or subscription helps this channel keep exploring the science of the mind in this unhurried, careful way. Sleep well. Your brain is still working, even now as you rest.